Can everybody hear me? Jeff?
We hear you.
Hey, Scott, can you hear me?
Yes, sir.
Okay, can you see the termination resuscitation up on the screen?
Yes, sir.
Okay,
Yes, we have it.
okay. Jeff, you there? Hey, Nelson.
Hi, Frank.
Okay.
I don't see him on the participant list.
Yeah, he was. He was there a second ago.
Maybe popped out.
I know, no, you're right, he's not there now. He was, he's doing it by his phone because he's at the thing for Al.
Okay.
Dr. Wasserman, you there? Yep, she's here.
Yeah, I mean, she's on the...
Hey,
There
hi.
you go.
I unmuted you.
Oh, yeah.
Hi.
Connectivity issue. I was trying to bring up the actual document on my computer so I could see it. I mean, I see that you have it up there, but
Right.
it's, obviously I can't use it. Let's see if I can get on my computer right now and so I can pull it up.
Okay, it's the Hudson Valley Regional Protocol.
Yeah.
Oh,
It just
here's Jeff.
Oh, good.
Okay. Hey, Jeff. Jeff?
You know who sent it? Was it Karen? Who sent the?
Yep, I'm here.
Okay, hey, how are you?
Good.
Okay. Okay, so we have 23 people on. So. Okay, so a couple of things we wanted to talk about. I think Jeff had some good news to share. So you want to talk about that first?
Sure. So I'm actually standing outside the main lobby right now because we're about to discharge our 400th COVID patient. And patient number 400 is your Al Sisolak. So he'll be leaving momentarily.
That's great.
That's cool.
Yeah. Okay, so on the other news standpoint, some of you know the state put out a fairly aggressive termination of resuscitation cardiac arrest protocol, which I guess got into the press, especially down in New York City, and was met with a lot of, I don't know, resistance, or I don't know what you want to say, but the Commissioner of Health, who had to sign off on it, then rescinded it. So we're back to operating under the termination resuscitation protocol that's up on the screen here. So we just wanted to review and answer any questions that people may have on, that protocol. So, Jeff, I don't know if you could see it or not.
Right. Yes. So the existing protocol, the collaborative protocol, is in effect currently.
Yes.
And the only thing that hasn't been rescinded yet is the don't transport if you don't get ROS.
Okay, so just I'll read through the requirements for termination. So the patient has to be over the age of 18. The arrest was not witnessed by a bystander or EMS. There was no bystander administered CPR. No automatic external defibrillator or manual shock delivered. No return of spontaneous circulation up to the time determination is considered. And at least 20 minutes of resuscitation has been provided. So that's the criteria to then make a decision on whether or not to
Right.
call or to terminate. So.
Right. So if you could, so you previously could terminate, you can again now the way you always had been, but there's no aggressive protocol with not starting if there's non-shockable rhythm.
Right. And then there's medical control consideration, which is you can call medical control for anything not covered in the above protocol. So anything you just reviewed, if there's something outside of that where you feel be worthy of terminating, you can call medical control for permission. So. Okay, so does anybody have any questions on that? Okay, I know it's a little. Anybody have any questions on the termination or anything like that?
I would just encourage people to use medical control. I mean, again, the protocol is the protocol, but for extenuating circumstances, you know, if you see something that is whatever unsafe or you're not sure, just call medical control. We'll be more than happy to talk you guys through it.
Okay.
Right, agreed. You can never be wrong for calling medical control. So that should be the message.
Okay. Okay, does anybody have anything for Dr. Raybridge or Dr. Wasserman? Okay, a couple of things people asked me maybe just to discuss was the return to work. In other words, what would be our criteria to allow people to return to work? So.
Well, I'll tell you what New York State says right now. Personally, says that if you have symptoms or you tested positive, it has to be at least 7 days from the time your symptoms started, and 3 days, at least 3 days previous before you go back to work, you can't have a fever, or Advil or whatever.
Hold on one second. I gotta.
Yeah, maybe.
Let me mute Jeff.
Yep.
Yeah, thanks.
The happy music.
Yeah. So, and then the other criteria is that your symptoms have to be improving.
Right.
You know, there's no, so that's what New York State says. So if you got sick on Monday, you got tested, it was positive. Let's say by Wednesday, you don't have any fever, then the earliest possible day that you could come back would be Monday. So 7 days from that time. However, even if you still have, like, let's say a cough or something like that, they say you can come back. Now, I personally don't believe that you know, can't be contagious. You know, if your symptoms are improved and it's been 7 days, I still think you can, personally, I think you can be contagious, but I think New York State and a lot of other states like New Jersey enacted these rules so that we didn't lose our workforce completely. So there's no scientific consensus as to when you're not contagious anymore. You just don't, you really don't know. And it's almost counterintuitive and contradictory when they say we discharge a patient from the hospital who has COVID and we say, okay, continue your quarantine for 14 days, but we're telling our workforce they can go back in 7 days. But it is what it is. So you can come back, you can return to work within 7 or at 7 days. That would be the minimum period from the time that you develop symptoms. You know, I don't know how frank you guys are approaching it. You know, our hospital basically is going by the New York State guidelines where it says you can go back after 7 days if you have not had a fever for 3 days and your symptoms are improving. But they're also leaving it up to us as to how we feel. Obviously, if you're still short of breath and you can't walk up a flight of stairs without stopping, then you probably shouldn't be out on the job.
Right. So I asked Nelson to sign on and just review with everybody our guidelines and what we're doing.
So
Yeah.
those are the same guidelines that we're using, actually. The 7-day isolation period, fever-free for 72 hours without adjuncts, and symptoms are improving, but you have to wear a mask up
Right.
to day number 14 from the onset of symptoms.
Correct. A surgical, it doesn't specify whether it be a surgical or an N95.
Correct.
Any type of mask.
Dr. Wasserman, don't you think that that's kind of a horseshit answer for that, considering that those of us who are actually working trucks are sitting within 2 feet of each other? A surgical mask isn't going to do squat.
Well, the purpose of wearing a surgical mask is, you know, it doesn't prevent the transmission. It doesn't prevent you from breathing out the sides of a surgical mask, but nor does an N95. You could still breathe out the sides of it, and you could still transmit, viral particles. The whole point of an N95 is to protect the wearer. So surgical mask doesn't really protect anyone. It just kind of decreases the amount that you can shed your virus by decreasing the amount that, what you might spray as when you breathe or cough or speak or whatever. No more so than putting your hand or your elbow over your face when you sneeze or cough. But if someone is wearing an N95 mask, that's designed to protect the wearer. So if you were sitting in the cab of your ambulance 2 feet away from your partner, conceivably they would be protected if they were wearing an N95 mask and you were wearing some other mask. But do I think the whole thing is horseshit? Yeah, I think the whole thing is horseshit. But we have absolutely no scientific data to go on. I think we're all living the same uncertainty as far as, listen, I stayed out an extra week because I didn't want to spread, just the possibility that I could. I wasn't working clinically. I think if I were working clinically and they needed me to be there, I would be there. But a lot of the stuff that I can do non-clinically, I could do from home. And so I had that, if you want to call it a luxury, to stay home just an extra couple of days. I mean, I haven't had a fever since Saturday, so I technically could have gone back to work today. We're kind of all flying by the seat of our pants here. We're trying to make the best decisions that we can so that we can, help our staff members, our partners, and our patients the best we can. So it's a tough decision. I mean, it's tough for the employers because we need to have a workforce. It's tough for the employees because we need to be safe and we don't want to get everyone else sick. But it's hard. There's no easy answer here.
Well, I wish you a speedy recovery. We're going to go out on our next job. Thanks
Okay.
for the answer. Thank you.
Thank you.
Rob.
Thank you.
Does anybody else have anything? Okay. Everybody's clear on our internal policy as far as, the surgical mask when you're in the vehicle, the self-checking before the start of your shift, your temperature and stuff like that, because I've gotten a few texts from people asking, or I guess asking me to remind everybody because they have some partners that are refusing to take their temperature, refusing to wear a mask in the vehicle and stuff like that. So that is our current policy.
Frank, I have a question for you.
Go ahead, Mark.
Say if you're taking like a leave or Tylenol due to pain from like your shoulder killing you, arthritis or something like that, do we need to be contacting a supervisor every single time when we answer yes on that form?
When I've been getting that phone call, I've just been telling them to stay at work. So, again, it could be masking if you have a fever because of the fact that you're on it, but what are we going to do?
Right.
No, I understand that you're telling the people to stay at work. I'm saying, do we need to still be contacting a supervisor every single shift that somebody works?
I'd ask Nelson what he wants
So
to do.
the only reason that question is being asked in there is not only for the fever masking, but the purpose is to consider the totality of it. If today you're taking it because your shoulder hurts, that's wonderful. If next week you're still taking it and you have a sore throat, a cough, and you may have lost your sense of taste, then you kind of have to look at the whole thing holistically.
Okay.
So, all things being equal, you kind of have to play it by ear, and really that's up to the individual provider. I mean, we expect you to have some modicum of common sense with respect to this. And it's like Dr. Wasserman said, we're in uncharted territory with this. I was speaking, my wife is a licensed medical provider, and I was speaking with her about it, and she cited the fact that the science is all over the place with this because we're still learning about what we're dealing with.
Right.
So apply some common sense to this. If you spoke to Frank yesterday and he assessed the situation with you and told you to come to work, and then the next day you're still in the same boat with respect to the medication and nothing else has changed, then no, you don't necessarily have to call Frank.
Okay. I'm not taking anything. I'm just, because I've heard a couple people mention these things and stuff like that.
Yeah, and we work in EMS. A lot of people take some type of NSAID or some type of over-the-counter medication to help them make it through the day. pain wise. I understand that. But again, it's so that, we have some degree of an idea of what's going on with you when we talk to you about it.
Okay. All right.
And we
Thank
can
you.
assess it, and we can assess it based on the current circumstances.
Okay. We lost Jeff. He got disconnected. He texted me, so I guess he's at the festivities for Al. Anything else anyone wants to discuss or go over?
Frank, I have a quick question clinical question for Dr. Wasserman on not the cardiac arrest protocol, but a quick clinical question for how we're dealing with these cardiac arrests now.
Good.
Okay.
Dr. Wasserman, now that we're using supraglottic airways as our primary way for managing the airway on cardiac arrest, I had another one Sunday night where I was getting really high end titles with a King airway, like in the 50s.
Okay.
Again, it's the second time it's happened to me in a week. Is there any reason clinically that we should be seeing unusually high end titles with a supraglottic airway versus an ET tube that you're aware of?
And you had good breath sounds and everything?
Yeah.
Yeah.
Okay.
Yeah. Off the top of my head, no, but that's a good question. I mean, I can look into it and get back to you. Trying to think where you'd have good higher.
I mean, again, I kept thinking I was getting Ross back, but
yeah. But even in the 50s, I mean, that's I have to look. I can't. And you're fairly certain it was properly placed and everything like that.
My partner placed it. I didn't double check. I was doing the IO and meds, and my partner placed the airway. I don't, I can't say for certain, but.
Let me look into it. I'll see if I can find any literature out there. I can't think of anything off the top of my head why you would see that. I mean, let's say the patient, but you didn't have Ross,
no,
right?
No, for sure not.
I don't know.
All right, I was just curious.
Yeah. Maybe your CPR was that good.
Well, was it mechanical?
There was a Lucas, but.
It was Lucas? Yeah, but
Yeah.
still.
But still, I've never seen that with, an ET tube.
Right.
No. I'll look into it.
Is in pH in these patients, and that could be throwing your end tidal CO2 off the
Maybe.
chart.
You broke up a little bit, Scott.
I think the increased pH levels, the acidity levels in these patients are throwing off the end tidal CO2 values a little bit.
Is that what?
But why would you? I mean, you would expect to see that in any type of resuscitation. No, I mean not just one with a supraglottic airway, right?
Yeah, any exhale you would tend to see it. I don't think the airway really matters.
Right.
Okay, after we get off this, I'll see if there's anything. I'll go onto the internet. Yeah. Just one thing as far as the Zooms go, some people are signing in with like cute names. So I don't know that it's actually one of our employees, so I'm not letting them in. So if any of your fellow employees are complaining that I didn't let them in, if it's a name that I don't know, I'm not letting them in because you've heard about all the privacy issues and the Zoom bombing and stuff. And also people are signing in with a phone number that doesn't, I don't know the phone number, I'm not letting them in. So if you're trying to sign in from your phone and you have a smartphone, you could download the Zoom app, make an account, download the Zoom app, and then sign in via the Zoom app from your phone, and then I'll see who it is. So if anybody's complaining they weren't able to get on, that's the issue. Okay, do we have any other questions? Anything else we want to talk about?
Frank, I just have one thing.
Sure.
I just want to let everyone know that the CARDISM has been deployed in all the RPS stations and gear and all the mobile care gear. So that's up and running.
Okay. Also, Jessica put up on CenterLearn the in-service. So if you haven't had a chance to do it yet, please sign on and do it. It has the video and the different documentation and a quick quiz at the end of it. Okay. So I asked if we wanted to do this, and there was a resounding yes, and we got 35 people on. So I guess we will continue. I'll set one up again for next week. And everybody stay safe, unless anybody has any other questions or anything else they want to discuss.
I just want to say to the people that are attending that can't be at work right now, I hope you're feeling better, and we look forward to your return as soon as possible. Thank you.
Yeah, Nelson doesn't want to go out in the truck. Okay. Okay, guys. Everybody stay safe, and we'll see you next week. Thank you. Take care.
Thanks.
Thank you, Dr. Wasserman.